Hello, everyone. Thank you so much for joining today. My name is Jenna Groman. I'm the Director of Global Communities of Practice at the Vaccine Institute, and it's my pleasure to welcome you all to today's event on COVID-19 mass vaccination sites, best practices, lessons learned, and the path forward. Next slide. As we give everyone a moment to join today, please do share your name, your organization, and where you're joining from in the chat. We also encourage you to use the chat throughout today's session to share questions for panelists and also share your own thoughts and experiences with others on the line. Today's session is being conducted bilingually with live interpretation in French. So please be sure to select your language of choice under interpretation at the bottom of the screen at the globe icon. Next slide, please. The Global Mass Vaccination Site Collaborative is a joint initiative led by the Vaccines Boost community and Ariadne Labs. And we've been working to provide live programming, resources, accessible tools, and experts to assist staff as they plan for and operationalize mass vaccination sites in low and middle income countries. We have been doing this over the last several months through both an open access website that has been curated, globalmassvaccination.com, along with live events related to mass vaccination rollouts and ongoing discussion within the Boost community. Next slide. Boost is a global community of more than 2,500 immunization professionals from more than 135 countries. Boost enables immunization professionals to connect with peers and experts, learn skills that build capacity and advance careers, and lead immunization programs in challenging situations. So we welcome you all to join Boost and join the community and continue the discussion through these different avenues. Next slide. And as noted, Ariadne Labs is partnering with Boost on this initiative. Ariadne is a joint center for health systems innovation at Brigham and Women's Hospital and the Harvard T.H. Chan School of Public Health. Ariadne has been working since the start of the COVID-19 pandemic to develop evidence-based decisions to support public health decision makers. Next slide. The Global Mass Vaccination Site Collaborative grew out of an urgent need to accelerate vaccinations for COVID-19, but the experiences and learnings that we've been exploring throughout this initiative have much broader applications. So in today's event, we'll be exploring the impact of these mass vaccination sites, what remains to be accomplished, and lessons learned that we can leverage to help us reach our vaccination targets. So to kick off today's event, I will first start and introduce our moderator for today, Dr. Eric Guralnick. Eric, I'll turn it over to you.
Great. Thanks so much, Jenna, and really excited to have our panelists today. First off, we've got Dr. Imran Mirza, who is a health specialist at UNICEF. He's been leading a great deal of collaboration across various countries, really focused on various ways to deploy vaccines. And has been a great partner throughout this exercise. Anna Rapp, who's a senior program officer at Bill and Melinda Gates Foundation, who really led us through development, identification, and the birth of this collaborative. So we're grateful for Anna. She's really going to focus on public-private partnerships and moving forward towards more needles and arms and vaccinations throughout the globe. And Vidya Simpath, who we initially were connected with through Anna. She's the director and team lead of data analytics at Village Reach. She's done some really pioneering work at multiple mass vaccination sites and other types of vaccination sites around the globe. And we're grateful, Vidya, for your leadership and innovation. So with that, we're going to open it up for some questions that we've prepared with the team. And after we've walked through those questions, we're going to open it up to the group for questions. When we do get to the question and answer period, I would ask that you just raise your hand icon or put it in the chat, and we can either call you out so you can share with the team here your question, and or if you put it in the chat, we'll go through and answer those questions through the chat to the team. So great. So the first question for our team here is, mass vaccination sites have played a critical role in COVID-19 vaccine delivery strategies. What are some of the major successes we've seen in this time? What best practices stick out to you? Let's start with Anna.
Thanks, Eric. Thanks, Jenna, and thanks both for having me. Good morning, good afternoon, good evening, everyone, wherever you are in the world. A few things stand out to me here, and perhaps I'll be even a bit more general than talking just about mass vaccination as well. One of the things that stands out is that we've seen vaccination efforts, both mass delivery and not, stood up faster than ever before. That has meant a real mobilization of all kinds of resources and effort, robust planning, staffing, funding, cross-sectoral cooperation, sometimes in modalities that had never been used before, and to reach populations that are really quite unusual for routine immunization programs. So that galvanization, I think, has been a tremendous success. I've been incredibly impressed to see efforts moving quite quickly to get off the ground. We've seen ingenuity and innovation around how to do this, around reaching communities that aren't typically touched by the health system in this kind of way, or the routine immunization system. For instance, thinking about reaching people where they are, whether that's thinking about the social safety net and in South Africa, and knowing that vaccines reached people in the queue for their grants, their pensions, or thinking about locating vaccine sites where people gather in transit areas or in places that are appealing for people to come. I believe Vidya will probably talk about this a bit as well, but the use of local data and intelligence about what the situation is hyper-locally, I think, has been a tremendous success. Taking all of the evidence around who you're reaching, who you're not reaching, and why, and being quite nimble and flexible in thinking about how vaccines are being delivered. I think that's also been a success. And then I think there's been quite a lot of success in trying to share what's working and what's not, and to be collaborative and to learn from one another. And I think in the case of COVID-19, as it's affected the entire world, it's been really interesting to me to see bi-directional learning, where best practices from low and middle income countries are influencing sometimes what's happening in high income countries, and vice versa. So I think there has been a lot of success, despite some of the challenges that still remain.
Great, Anna. Thanks so much. And it brings up a great point. While we're listening to the panelists, this last point around bi-directional learning, which is the whole focus of this collaborative. Tell us what you think in the chat. Has this been helpful, this collaborative, over the last 6 months, and how can we help you in the future? Please feel free to throw that in the chat. So let's turn this over to Imran. What are some of the major successes we've seen, and what best practices stick out to you, Imran?
Thanks, Eric. And I think Anna has already mentioned some. I think this is probably is one of the best example of collaboration of so many partners, of starting from the lab, from where the vaccine was developed, and then reaching to the arms of the people in the rural areas within 1 year or 1.5 year time period. And this cannot be done without a huge team efforts and the collaboration of the various partners at all levels. So rest she has read. Plus another, I think the great success of this vaccination is till now, majority of the global programs in the majority lower middle income countries and many countries, vaccination was for the children. This is one of the best one where the vaccine is for the adults, even up to the elderly, for the disabled and everyone, which is the biggest challenge some of the countries facing, that they don't have a record or they don't have access to them. So this is still, we are not saying we are 100% there. There are still a lot of countries, there are about 30 countries who are still less than 20% coverage. There are countries who are facing challenges to reaching the disabled people, reaching the elderly people because of the various issues, geographic issues and other issues. Last year in 2021, we know, although till now we have delivered more than 1 billion doses in the low-income countries, but last year there was a huge demand, but there was access to the vaccines was limited to the low-income countries. It was more access for the developed countries. Now, as vaccine is available for the low-income countries and everywhere, so we are in January 2022. We have revised our from the COVAX side, from the CRD, we revised and established this COVID vaccine delivery partnership, which is a partnership between the WHO, UNICEF, and Gavi. And UN Secretary General has appointed Ted Chaiban as a global lead coordinator. So we are now supporting all those 92 countries, especially the one which have less coverage till now, so they can achieve their targets by end of 2022. And in this ones, we are doing a lot of efforts. Still, there are challenges from the community demand side, because as in the developed countries, the restrictions are over, people are thinking, oh, there's no more problem with the COVID vaccine. So there are challenges. I'm not saying there are no challenges, but I think there are a lot of success. There are a lot of health system strengthening going on. The countries has also started thinking how they can use best use of this COVID support to develop their systems, address those risk bottlenecks in the health system and immunization systems. And that's the discussion is very good positive sign that that in future, once the COVID pandemic will be over, how we can make a best use of these efforts and resources and all those inputs which has been given to the countries, how they will be able to use them for their health system strengthening. Over.
Great, thanks, Imran. Yeah, that's a very focused and clear mission here, is to leverage our experience and advance it, not just in COVID, but other vaccination efforts, as you referenced. Thanks, Imran. Vidya, anything to add about strengths or successes or best practices?
I think I had two things that I noted down when you posed that question, and between Anna and Imran, it was covered. And so I'll just reiterate, for me, the two main ones that I hope continue long past the COVID-19 focus is the way in which collaborations took place, both at the global level, but also really organically at the local level as well. And the second is just the way in which, over a matter of 6 months to a year, countries were able to pull large swaths of their population that had never really been a focus for vaccinations, but also general health services, which is the general adult population in most of the countries. And so the fact that this was able to come together in such a limited time is, I think, one that we should just constantly celebrate, while we also take stock of where we are with our target rates.
Great, thanks, Vidya. Thanks for emphasizing those key 2 points. So, mass vaccination sites have been highly impactful and efficient in maximizing throughput. As each of our panelists have already said, we've established, or many have established, these sites in unique venues, in unique ways, with unique methodology. And so, what have we learned about mass vac sites that are appropriate for delivery strategy, and what is critical for mass vaccination sites to be efficient and effective? Vidya, you want to kick us off?
Sure. So Village Reach has supported the sort of design and the implementation of mass vaccination sites in 3 countries so far. So we have a few learnings for when I think they're most effective. So off the bat, I'll say they're not a long-term delivery strategy, and they have a really specific moment in time when they can be effective, and that's closely related to demand for the vaccine. So starting with the US, for instance, where we did the first COVID-19 vaccines mass vaccination site work, the sites in the US opened up within the first month or 2 for when the vaccines first started getting rolled out, and demand at that point was sky high. And these temporary mass vaccine sites were crucial in meeting that demand because the existing network of health centers and hospitals simply could not have kept up with that sort of crowd need, and also continue to provide other health services. So as that supply and demand fluctuate, there is a need for particular delivery strategies, and that need for these particular modalities will also surge and wane. So countries, I think, should be willing to modify their mode planning as well as their staffing schedules as that local data becomes more and more available. And I think there's a need to keep both the strategic and the operational plans really nimble so that these pivots can be made. I'll also say that, we're talking about mass vaccination sites, but they're not a standalone concept. Countries really should have a strategy that looks at all delivery modes for rolling out vaccines at both the national and the subnational level. And this strategy will really then empower them because it'll provide a framework for action so that they can figure out when to deploy which type of modality. So mass vaccine sites are effective in certain situations. I'll also say that cross-sector partnerships, as Imran and Anna mentioned, they're essential in keeping the costs and the resource needs for these sites really manageable. So if we want them to be efficient and effective, we always talk about costs when talking about these 2 pieces. And so from our experience, the one-time setup costs for a single site can go in the thousands of dollars. And then the monthly recurring costs can also be in the thousands of dollars. So this can become really cost prohibitive when you're looking at conducting, say, like a 4-month site or a 6-month site. So cost sharing is really crucial. And in order to cost share, you need partnerships. So we have lots of examples where, we've partnered with WHO, for instance, where after WHO witnessed how effective the mass vaccination site in one country was, they said, how can we help you? And we said, the single biggest cost driver for us is renting these very nice tents. And so WHO then looked within their house and said, we have 4 tents that we can provide, so that when we opened 4 additional sites, we didn't need to get that cost. Similarly, I think costs around staffing end up becoming a huge cost driver. So how can you look at staffing model partnerships between the government, implementing partners, and also sometimes private sector providers to keep the staffing model one that also allows the government to continue to run their other health services. There also has to be really strong linkages between the teams that are working on demand generation and the teams that are running the actual sort of mass vaccination site operations, because there are even some slight shifts in how the community is perceiving the vaccine or perceiving the site is crucial for the site operators to know about so that they can shift their strategy. So I think my last point in terms of how to make sites effective would be to stress on this demand dependency for mass vaccination sites. Modalities such as outreach or campaigns these modalities go in search of people and they bring the vaccines directly to the people. But mass vaccination sites best serve people who come to get the vaccine. So at an absolute minimum, people must understand and they must know when they can get a vaccine, where they can get a vaccine, and how they can get it. So really simplified communications and messaging systems are key to this. And finally, data. It's hard to know how to respond to a community's need if there's no information coming from that community. So we've done things like in every one of our sites, we deploy exit surveys that ask really specific questions about how the community is feeling that day and how are their families feeling, how are their friends feeling. And using that data, we've been able to constantly tweak the strategies with which we are reaching the people as site operators. I'll stop there.
That's great, Vidya. There are so many wonderful points that you brought up there. It's interesting. I was, one, as you said, we learned pretty early that this is one intervention, and there are many. There's got to be a suite of interventions, as you've expressed. Either coming to or meeting people where they are, as many have referred to. And so your organization has been quite nimble at leading this work, and so we're so thankful for that. It reminds me of a quote from a former director of the CDC that said healthcare accessibility is directly related to geography, and it's just like what we see with zip codes and the relationship in the United States, zip codes and the relationship to mortality. So it's an interesting experience that we've gone through, understanding the suite of being nimble and adapting to the various geographies that we have and communities that we have to help support them. So Imran, thoughts on when are mass vaccination sites appropriate, and how do we make them effective? I know you've got a lot of work you want to share with regard to Afghanistan, for example.
Thank you, Eric. And I think Vidya has covered most of the things. I agree. This is not only the one of the delivery strategy for COVID vaccine. It is a new delivery strategy, which is governments, ministries were not used to it. Because normally in the routine programs, it was a fixed site, normally health facilities, health centers, where the children, as Vidya was saying, that only people come there, or during the campaign, there's a strategy for the temporary fixed site where a vaccinator team will go to the village to village. They will sit under the tree or in the mosque or church somewhere for a day, vaccinate that, and then they move on. So countries were used to that kind of strategy. This is a temporary fixed site with the multiple vaccination teams at a one place providing. So this is for them is a new thing. Plus they were facing a problem to understand the concept, and then also agree that because it's a mass vaccination site with multiple teams, so they can vaccinate minimum at least 500 people a day. So they need the resources, how they can bring in so many vaccinators. They moved vaccinators from different places. So that is one of the things. Second thing, as she mentioned, is a demand, because these sites are very good for the urban, highly populated areas where you have bring number of people, more people are available, so you can achieve your targets, what you are used for this one. I have a very good example now, like for example, from Afghanistan, which like people think that is like it's a complex emergency for the long time. In Afghanistan, in about 7 or 8 major urban cities, they have established these mass vaccination centers. And interestingly, these centers were established by the women and for the women, because we all know that Afghanistan culturally is culturally that women are not allowed to mix up with the men, and they want to separate. So this was an initiative which was taken last year, and by the government with the partners, everyone, and supported by the basic package of health services. So the women groups, they established the sites, which is run by the women, and it's giving vaccine to all the women in that one. And one of the achievement, if you see in Afghanistan, that almost 30-40% of the coverage of Afghanistan is attributed to these sites, because here this is what the women are getting vaccine. They are so doesn't mean that is a women's side, so men are not allowed to go. Men can go, but men don't go because everyone knows that this site is for the women, so they know that the sisters, their daughters, and their mothers, they will be going there, and culturally it's not appropriate. So these is a very good example on that one, which is like a separate need. And the challenge what come is same like in Afghanistan when I was discussing with the partners who are supporting this one and managing. They said the first was issue the same challenge to understand for the government that why it is required, the mass vaccination site, because if their country really needs to reach their targets as per NDVP, they need some site where they can vaccinate much more people. Number two, what resources will be required? Like there will be need so many vaccinators, so they have to move the vaccinators from the different sources. And if the shortage of vaccinators, they have to train those people. They need the admin people to manage those sites. So those are the challenges. And as well as what I was told, in some of the sites are working very well. Some of the sites, they face a challenge of the low turnout because people doesn't know that this site exists. So as Vidya was saying, not only the demand for the vaccine, but communities should know that this is a place, in this place where you can go and get a vaccine. So in addition to the community demand, but knowledge for the people to go there. The example what we give, like Vidya was giving for the US and those ones, these are the developed countries where everything was available on the internet and on the WhatsApp. In developing countries, that luxury is not there. So that is a word of mouth thing to the communities in those places that, oh, there is a site there, you can go and you can get the vaccine. So these are some of the challenges, but we have there are some examples in Africa where now countries are thinking, a lot of like Kenya is thinking to establish some of the sites. So this because as I said, there is a new kind of delivery strategy. So countries, ministries now are coming up. And I think panels like this one or this collaborative, that we still need to share lessons learned and the good practices from the various countries as much as possible to the various countries that this is possible. And from the COVID delivery partnership, now we are start working to collect the information of the partners, NGOs, who can help the countries in developing, establishing these sites, as well as provide the technical support to the countries to manage those sites also. So then and there's a funding is available. So then we're going to provide the countries that if you are interested to establish, you will have the funding, you will have these partners who can support you in establishing and managing those sites. But the main point will remain, we need to have a good community demand to receive the vaccine, because even if we establish site and we have a problem of hesitancy among the community for the vaccine, people may not come and the return of investment will not be too much. So we have to weigh in the investment we want to put. We don't want to have a very 5-star vaccine site. We need a site where people can come, they don't have to wait, they don't have to face any problems. They come, they get the vaccine and they go home. So there's a thing we see how, and then also adopt it with the local context. If culturally there's some incentives, if the country they're seeing that they want to have a separate genders, then they have to think that, okay, this site will be only for the women, this site will be on the man, or if there's another issues. Plus, we have to make sure that wherever the site will come, it should be someone which is accessible to the disabled also. So disabled people who are coming, or at least some partner, as we are talking, I think we heard about these partnerships, what Vidya was mentioning, or any partners who can provide those services for the disabled people or elderly to bring them to the sites for the vaccination. So it all needs a lot of collaboration. Thank you. Over.
Great. Thanks, Imran. A lot of wonderful points there. I want to come back in a bit, if we have time, to communication strategy. And the follow-on question will be, what techniques or tactics did you observe from sites, from organizations, on best ways to communicate accessibility of vaccination sites? And if everybody could go on mute if you're not speaking, that'd be great. Thanks. Anna, anything to add?
I think Imran and Vidya covered this one, Eric. Thanks.
Perfect. So a lot of great work. A lot of great work's been done since the beginning of this pandemic, getting vaccinations out there. Imran mentioned there have been over 1 billion vaccines deployed in lower middle income countries. So the question is, where do the gaps remain in lower middle income countries, and what are the opportunities that potentially mass vaccination sites can address? Let's start with Anna.
Sure. I think we all know that there are still some challenges and gaps. We're far from done with this pandemic and with this challenge, unfortunately. One of the things that is concerning me is a loss of momentum, especially as restrictions are easing and there's an eagerness in all countries, but particularly in higher income settings, to be past the end of the pandemic. And I think there needs to continue to be attention around reaching everyone who needs a vaccine. That begins with the most vulnerable, healthcare workers, the elderly, those with underlying conditions, but really means everyone in the long run. So I think that attention is one piece that's concerning to me. We've heard quite a lot of conversation already around demand. That continues to be on my mind. The urgency has changed in the last 6 months, I think, for people around COVID vaccination, and even in some places where we see public polling showing relatively high willingness to vaccinate. When people are asked a question like, would you consider getting a COVID-19 vaccination? The actual follow through to finishing the endeavor of getting 1 or 2 or 3 doses doesn't match those willingness numbers. So I think making COVID vaccination as convenient as possible, not having to go out of your way to get it done, continues to be a challenge. I have no doubt we'll continue to see new variants. We'll see countries across the world figuring out how to introduce boosters and on what cadence. We may see pediatric vaccination increasing in some places. And right now, I think we're at an interesting moment where we've shifted from a deep constraint of vaccine supply. If we were talking 6 or 8 months ago, we would have been talking about low and middle income countries not yet having enough vaccine to vaccinate their population, to having really ample vaccine supply at a global level, and sometimes maybe even oversupply. And yet we're still not reaching local targets and global targets in a large number of countries. As Imran mentioned, a number of countries are still in the single or low double digits. So I think there continues to be a need to think about strategies to accelerate and to think about reaching those most vulnerable people and continuing to keep the pedal on the gas pedal on, despite a number of competing priorities for governments and for all of us in the community.
Great, thanks, Anna. Yeah, when you introduced your initial response, the COVID fatigue is setting in. It's very clear across the board in so many different domains, and it's something that we've all got to work through. Imran, your thoughts on, I know you've referenced a bit of it, the remaining gaps and opportunities, particularly for mass vac sites.
Thanks, Eric. Yeah, I think this is the challenge what we are facing in low-income countries, that as the restrictions are being lifted on the developed countries, so a lot of countries, people think that there is no more problem. However, the vaccination rates are very low. Plus, I think there are few things probably. Initially, when we started this concept mass vaccination site, we were thinking to have at least like 500 vaccinations per day in a site. maybe I think in some areas, some countries, depending on the situation, we may have to reconsider or adopt kind of smaller mass vaccination sites, like in the bus terminals, or where you can find a lot of people. And then it can also be a temporary that, okay, same like mass vaccination site, but in a smaller scale, and that where the target will be around 100 people per day so they can vaccinate. So then we have a multiple sites in the urban areas or even smaller urban areas, but where the marketplaces, where countries can see that they have a lot of people, because these sites needs people to come and vaccinate. And then we can, and there in many countries, like I thought the comment, yes, still there are countries where we cannot have a site because there needs the outreach activities, which is far off areas. So that's one delivery strategy. But now we may see about how we can have a redesign smaller mass vaccine sites for the smaller urban areas, or where we can find more people. And that's will come on country to country, case by case basis, and depending on the local. Plus, demand is one thing. Probably we start thinking of using these sites where we have to provide some other health services, health or nutrition services to the communities. So then it can create also a demand, and it will be more cost effective. That is not only the COVID vaccine is giving. In a lot of countries, Africa, it's not only the COVID vaccination. They have a problem with the routine immunization of the children also. So if countries can start thinking that what can other services can be provided through these sites, so people will have a much more opportunity to get the sites at the one place, one window shop, where can get a much more site. It's not a health facility, but at least preventive services where we can provide to the countries which are like, just an idea, the countries where we have a malaria problems, the bed nest distribution or other things, but other preventive services, if we can adopt those countries, and then we can see how it will work out to become more sustainable, and those ones. Over.
Great. Thanks, Imran, for those comments. And anything you'd like to add, Vidya, about key opportunities and gaps that remain?
Yeah, just two quick comments. I wanted to respond with an example, actually, when Imran was talking about, as we learn more, constantly unlearning what we thought we knew. And so we had the same feeling when we started this work. We thought a mass vaccination site is 500 people a day, 1,000 people a day. And the work that we're doing in Côte d'Ivoire and in DRC is a really great sort of comparison, because in Côte d'Ivoire, we thought it's going to be thousands of people a day. We need a huge site. We set up a mass vaccination site that can cater to 1,000 people a day on the grounds of a sports complex. So there's lots of space for parking, and the space within the site is big so that people are not crowding together. And then in DRC, because there was so much uncertainty, we just did not have enough local data to be able to guess what is the community's acceptance of the vaccine. We decided to start on a much sort of lower square footage. And so the DRC site, the first site, was set up to cater to about 500 people a day. And our learning has been that that actually seems to be the more successful model when you haven't reached saturation point in terms of reaching everyone that wants a vaccine. So in DRC, it's exactly what Imran described. In Kinshasa, which has something like 12 or 14 million people, we have a network of temporary mass vaccine sites that are vaccinating about 200, 300 people a day. But these are sites that are located right next to a busy market, or right in the middle of a traffic square that is next to the bus terminal. And then we have one that is right in the grounds of a large Catholic church in Kinshasa, where a lot of people go to receive their spiritual services. And so really thinking creatively about where are people gathering. And so this is, they're walking over to the church, they stop and get vaccinated, or they're leaving a service, they stop and get vaccinated. So thinking about opportunities like that, and it's not a one-day event, but you actually set up a site for a few months and reach whoever is passing through. So just a quick comment there. The other thing I wanted to say about where gaps remain, I read a study that was released by the Institute for Health Metrics, IHME, at the University of Washington. They released a study just, I think, this week, and they estimated that there was an unmet need for vaccines in Africa that was anywhere between, I think, 10% and 25%. So that's a huge number of people still seeking the COVID-19 vaccines. But unfortunately, at the global level, there's this framing of vaccine demand that puts people into either the vaccine enthusiastic category or the vaccine hesitant category. And I can tell you that just from our work in the countries where we're doing this, I can emphatically say that the truly vaccine hesitant are just a small minority. Instead, large swaths of the communities are generally supportive of vaccines, and they trust the process for the most part, but they're ambivalent about getting vaccinated. They want to spend their limited time looking for vaccines. So what does that mean for mass vaccine sites? There's still opportunities to deploy them in places that haven't reached a saturation point amongst those willing. And it comes down to governments and to partners really doubling down on this issue of access. Access to a site and access to information on where to get vaccinated and how to get vaccinated. So it goes back to, I think, the points that Imran made also about, it's word of mouth, it's communications, and it's really ensuring that people know what opportunities.
Let's open it up for some questions. I first want to do one from the chat, and then we'll get to Dr. Shankar. I see your hand is up. The first one, it actually builds video on what you just referenced, which I feel like is a question that comes up at almost every session. It's from Alfred Pack, and it says, how to deal with vaccine hesitancy. So any best practices beyond what you just shared with this community on addressing vaccine hesitancy?
I mean, there's a lot that I could sort of share, but just off the top of my head, thinking about how we did this work as site operators, we really worked very, very closely with community health workers. So we did exit surveys at each of the sites. Like I said, we ask people as they're being observed in the 15-minute waiting period, are you willing to take a very short survey to give us feedback? And most people, like more than 65% of people say, sure, I'll take the survey and I'll answer your questions. And when we analyze that data, over 50% of the people who came to these sites found out about the sites because of their personal networks or because of a conversation with community health workers. So we said, okay, this is something here where we can really have this lifeline to communities if we tap into this network of community health workers. And so in DRC, for instance, the government and Village Reach trained 100 community health workers over a 3-week period and really sort of used them as messengers for not just sensitizing them about the vaccines, but also talking to them about their own personal experiences with getting vaccinated and how they navigated that journey for themselves. It's a pretty uneventful webinar. So I'd say there are, quite a few strategies. And what I can do is actually put some links in place for some of the work that we've published on this so that there's time for other questions as well.
Great.
To start my first comment by relating this comment to Imran's suggestion of adding other services. The title of this commentary is that advocacy should not only be with people, but also with the ministries of health. One of the reasons is that they are exactly for what Imran was suggesting, are terrified that the replication of services outside of the current health service, primary healthcare, would move into high volume sites, And that is one of the reasons why many countries actually at the Ministry of Health level do not approve, stop, or have a lot of hesitancy whether this intervention of high volume sites for vaccinations is at all appropriate. So yes, we should also think about routine immunizations, but stop there and not add nutrition and other elements. High volume vaccination centers should, in my opinion, stay within that domain at all. Second short intervention. I think we can learn a lot from another intervention that has been moving towards now 21 million African men circumcised, and I'm talking about voluntary medical male circumcision. Our team has been involved in that over 15 years ago, and I think that a lot of lessons can be drawn, but nobody puts that together yet. Not a scientist, nor the Bill and Melinda Gates Foundation, nor UNICEF, or WHO have had a lot of stakes in that, a lot to learn from there. I want to expand. One before the last, I think that we are not at a level where we can talk about standardization of high volume vaccination centers or sites, but we should aim there. And as organizations like VDIAS and ours and others are having more experience on the ground and also in preparatory work, I think we should aim, and I hope this could be perhaps another area of collaboration with Gates and others. And lastly, I think that there is, after COVID-19, a strive for a new social contract, and a new social contract in many dimensions relating to our issue. I think that we can come back to the table and look at the experience of faith-based organizations and faith leaders who have contributed a lot to the advancement of polio vaccination, of Ebola just a couple of years ago. And the best we can in the new contract include them as societal influencers. I think we would also improve on the demand, the application, and perhaps the future of high volume vaccination centers. This is what we have been doing here out of Jerusalem, where we have erected over 105 vaccination centers throughout a diverse community settings and diverse community leadership, including Muslims, Christians, Baha'is, and Jews. Thank you, Eric.
Thanks, Nan. That was wonderful. 4 really critical points, all that have a lot underneath them that we could learn a great deal from. Thanks. Omolara, would you like to ask your question?
Hi, everyone. So I'm joining in from Nigeria, and in Nigeria, what we've been doing with addressing vaccine hesitancy is working with religious and traditional leaders. So we currently have a co-advocacy group on the Breakthrough Action Nigeria project, and we've been using that platform, you know, to reach out to people in different communities. So first of all, we pull them together, the members of the ACG, as well as religious leaders from different regions within the country, and let them understand the basics of why they need to get vaccinated and why it's beneficial to get vaccinated. So when we're able to clear that doubt, you know, in their minds and get them to also understand the benefits, then we use them to reach out to members of their communities, asking them to now go with the knowledge that they have gained and use that in mobilizing their communities. So at those meetings, we then ask them to come up with a plan, like a vaccination plan, when the vaccination teams can then visit their communities to actually conduct mobile vaccinations. So far that has been working, and it's been giving us results. Thank you, and over.
That really sounds amazing. You know, we're in a transition time where we don't have any of these webinars planned in the future, but boy, we'd love to dedicate a session with you and your team to learn from your experiences so we can all benefit. Thank you for sharing that. Adrian.
Yeah, thank you very much. And I'm happy that I've been part of this fellowship activity. I'm from the Philippines, representing the subnational level of the Department of Health. Presently, I am a new immunization program manager in the subnational level. I would like to ask your opinion or your advice or your strategies if you have. How can we implement both COVID-19 vaccination and routine immunization with equal priority? Because usually the thing that I have observed is still COVID vaccine is a priority of all the LGUs in our subnational level, and the routine immunization is less priority. That's why I am having difficulty right now in dealing with this situation in the implementation of the routine immunization. Thank you.
Great. Thanks, Adrian. And magandang umaga. Nice to meet you. Any of our panelists, would you like to take a stab at that? Go ahead, Imran.
Thanks, Eric.
Yep.
Thanks, Adrian. No, I think you have raised a very important question, because we are facing challenges of the low routine immunization. The governments from the WHO, UNICEF side, we are start discussing how we can use these COVID investments to improve the routine immunization. And we are looking for the various opportunities of integration. And we didn't discuss anything on of the digital technology and other things, looking how, while we are giving COVID vaccine, looking for the zero dose communities or zero dose children where we are missing the routine immunization. So if you said that you are from the subnational level in the Philippines, a lot of countries start thinking of liking integrated campaigns, that in case they are doing the measles or other campaigns, how they can integrate with the COVID vaccination campaigns, because for the campaigns for the children, child alone will not come. Child will always accompany with the parent or some adult. So at that time, they can check whether adult has received COVID vaccine or not. So the child will get the child vaccine and the adult can get the adult vaccine. So different countries are looking for the different opportunities depending on the resources, depending on the capacities in the country. Some countries are facing challenge. They said not possible. Some countries are going ahead on that one. So this is how we can see on the local concept that what is possible, and depending how we can integrate with the routine for the children as well as it. Plus, for the COVID vaccination, the people who are involved in the demand and those things, they can help you out to look for those zero dose communities. So children will not be vaccinated now, but at least you will have information in your area where those missed children are there, and then they can share that information with the health facility who is responsible for the catchment area of that one to go and check for the children. And so it's a different thing. One is the delivery. In addition to integration is on the planning or the monitoring, on the data collection. So these are different options which we can look at how we can make best use of these resources to look for those children who has missed the routine doses. Thank you.
Thanks. Thanks so much, Imran. Omalar, do you have another question or comment?
Oh, sorry, I'll just lower my hand.
Oh, okay, great. Thanks so much. Well, it's amazing. It's 57 minutes past. Somehow we went through another hour. We got through a lot of questions and answers. This has been an incredibly powerful session, and we're so grateful to Vidya, Anna, and Imran, our panelists, for leading us through this exercise. And most importantly, all of you, our participants. We've got 59 people on the board, which is, I think, one of our highest attendance rates. And it's been a really wonderful discussion. Here are the resources that we'll continue to have. Here are some resources out there. Again, the Global Mass Vaccination.com has a list of resources, our recorded webinars, an existing blog that has notes from each of these sessions. That site will continue to be maintained at least for the next year. We're thinking about how we may move forward for sort of 3.0 of this collaborative. So if you have an interest, if you have ideas, if you can share with us if this forum has been valuable. Please send us a note, and so we can continue to work towards vaccinating the globe. Again, really want to thank everybody's participation today, and hope you have a wonderful day. The last point, sorry, that last slide around survey, if you have time, please go to any one of our sites, again, globalmassvaccination.com. Go to the Boost community to take our survey and join the Boost community, which was here before COVID, is here, will be here after COVID, and really have been pioneers in the vaccination world. So thanks to the Boost community for your leadership. Okay, well, have a wonderful rest of your Friday and a great weekend. Thanks so much. Bye-bye.
Thanks, everyone.
Thank you, everyone.
Thank you.
Thank you.
Okay, thank you very much.